Good morning, good afternoon, good evening, depending on where you are. Thanks very much to the organizers for the invitation to present today. It's a pleasure and an honor to present in this session. By the end of 2019, there were 38 million people living with HIV, with almost 700,000 deaths and an estimated 1.7 million of new HIV infections every year, with a number 3 times higher than the UNAIDS 2020 targets. As such, HIV prevention must remain a key focus. The HIV epidemic disproportionately affects key populations in different countries and regions. Previous PrEP studies have shown considerable challenges in maintaining daily use adherence in these populations. Not by chance, these are the same populations that are most affected by HIV. Antiretroviral-based PrEP provides robust protection against HIV in all populations and routes of infection. By December 2020, almost 1 million people have accessed these prevention strategies. Countries with high uptake tend to have in common early adoption, national commitment to scale up, and programs tailored to populations at risk, offering community-led, accessible, non-discriminatory services and linkages to social support. While some people perfectly adapt, others may face barriers related to daily oral PrEP, such as HIV stigma, side effects, pill-taking burden, non-disclosure, and secrecy about pill-taking. Social activities that disrupt routine, misleading perceptions of protection despite missing doses, and difficulties in forecasting sex are some of the barriers related to daily oral PrEP and that may lead to pauses and discontinuations. Although PrEP is not meant to be a lifelong requirement, high adherence is needed during periods of use. So it's not feasible for everyone. You can see quotes from individuals using PrEP in different locations from published data that show that people really have difficulties in dealing with the daily PrEP strategy. The ultimate goal of the development of PrEP options is to have prevention technologies that will reach a wide range of people with different needs throughout their sexual lives. Alternative PrEP agents are being developed to increase the range of biomedical prevention strategies, options that attract those most at risk. Promising strategies include new oral agents, long-acting injection preparations, implants, immunotherapies, vaginal rings, multifunctional prevention technologies, and transdermal patches, among others. As you can see in this slide, I will start now talking about some of the long-acting options that are being studied in more advanced or less advanced stages. Carbotegravir is a potent small molecule strand transfer integrase inhibitor with attributes permitting formulation and delivery as a long-acting intramuscular medication. 2 studies have evaluated in phase 3, 2 large phase 3 studies evaluated CAM for HIV prevention among different populations. HPTN-083, as you can see here in this slide, is a phase 2b3 registrational double-blind, double-dummy trial that involved almost 5,000 HIV-negative MSM and trans women at high risk for HIV infection, who were randomized to a PrEP regimen containing either long-acting Carbotegravir or a PrEP regimen of daily oral TDF-FTC. Results showed 12 incident HIV infections in the CAB arm for an overall incidence of 0.32 per 100 person years and 39 incident infections in the TDF-FTC arm for an overall incidence of 1.22 per 100 person years with a hazard ratio of 0.26, confirming that CAB-LA is superior to TDF-FTC in the population tested in this clinical trial. And as you can see in your right, HPTN-084 is a phase 3 trial with a similar design that I explained for 083, to evaluate the efficacy and safety of CAB to prevent sexual acquisition of HIV in cisgender women with increased risk of HIV infection in Africa. This study also proved that CAB-LA is superior to TDF-FTC in this study population. Now moving to the Latrovir, that is another drug that is now in phase 3. Latrovir is a first-in-class nucleoside reverse transcriptase translocation inhibitor under investigation for prevention of HIV infection and also in having studies for treatment. So upon conversion of Latrovir to its triphosphate form, HIV replication suppressed through translocation inhibition and delayed chain termination. Activity demonstrated against wild-type HIV and drug resistance variants was found. Half-life in PBMCs is around 190 hours in adults without HIV, and complete protection was demonstrated upon rectal challenges in male monkeys SIV models. So this drug is now being developed in phase 3 trials, trial for MSM and transgender women, Empower 024, and for cisgender women in Africa, Empower 022. The Empower 124 also includes transgender men and non-binary individuals. Latrovir is also being evaluated in a long-acting implant with a potential to be used, suggesting the possibility for developing human implants with a dosing interval of 1 year or longer. And lastly, Lenapovir, that is also in development in phase 3 studies. Lenapovir is the first HIV capsid inhibitor that inhibits several capsid-dependent functions that are essential for viral replication. So preclinical data that showed that this drug is was highly effective in a non-human primate challenge model and support the clinical development of Lenapovir for prevention. The studies Purpose 1 and 2 will evaluate the use of Lenapovir as a sub-Q injection every 6 months for HIV prevention for cisgender women and among MSM and transgender individuals who have sex with men. Now moving to transdermal delivery systems, these are also being studied as an additional innovative design of drug delivery system for HIV prevention. This can also be a very interesting delivery system because there is already experience with hormone replacement, contraception. It has a discrete use. It's easily applied without the requirement of clinical staff. It controlled release of drugs into the systemic circulation. It's non-invasive, eliminates the first pass through the liver, eliminate peaks and valleys, and as many drugs fail to get through the horny layer of the skin, this may be an issue. So injectable agents also have pros and cons. It improves adherence, probably a lot. It needs less frequent reminding. It potentially healthcare visits can be increased because it has a schedule that is different from LA-CAB, from Truvada, and it requires more visits to the healthcare system. So we need to better understand and study how injectable PrEP will be integrated into the healthcare system. So historically, the introduction of evidence-based technologies into public health programs has been fraught with delays that result in missed opportunities for impact. These delays have been in part due to the lack of preparatory evidence critical for the introduction into programs at scale. Product registration timelines in low and middle income countries in special are usually longer and sometimes never occur. By behavioral and social science research has an important role to play in preparation for an era of choice of biomedical HIV prevention that includes long-acting antiretrovirals. Designing prevention studies that respond to the findings of the above research areas could promote effective, equitable access and engagement with emerging long-acting prevention modalities. It's critically needed to understand how to efficiently and effectively bring these PrEP products to people at risk of HIV infection who want to use them, building upon the lessons learned from the oral PrEP scale-up in order to prepare the field for this novel technology. Expanding HIV prevention options needs to be done while expanding PrEP coverage, ensuring that the introduction of a new PrEP modality increases access and reduces disparities in PrEP uptake, rather than simply providing alternatives for patients already engaged in PrEP. And this is a real major challenge. So, a few points to be really thought about how to implement long-actings. So we have the system level opportunities and challenges. The health system capacity that, as I mentioned, long-acting PrEP may need larger number of visits than with oral PrEP. With oral PrEP, at some places we are dispensing PrEP for 3 months. CAB-LA, for instance, will need the participant to come to get the injection every 2 months. That's something that may be a burden for the healthcare systems, depending on how well we are able to organize our health systems. The location of the service delivery, if we will or not be able to use community-based services, pharmacies, mobile health vans, in-home services. And we will need to develop a tracking system for the injections, a good retention system to bring those who are delayed for their injections, and a good and safe supply chain and logistics. Increasing provider awareness, the second level is the provider level challenges. So we need to increase the providers' awareness of PrEP guidelines and enhance training around prescription practices. And this can make a real difference for implementation. So systematic inequities in PrEP access, uptake, and retention limit their sustained impact on incidence in the highest priority population. So provider level factor may also play a significant role in promoting and sustaining health inequities. Defoe believes about the acceptability and suitability of long-acting agents for particular subpopulations could lead to automatic prescription of specific formulations based on group identity rather than by providers attending to the specificities of individual patients' lives. Providers are an unrecognized, hard to reach and hard to engage population, but new strategies that focus on increasing the perception of relevance of the research to their own practice could be developed, need to be developed. So, and now moving to product level challenges and opportunities, CAB-LA was proven very safe. Adherence is an issue, adherence to the visits and to the injections, as I mentioned it. It is a discrete product that may really be very important for those facing major stigma in their lives. And we need to be still concerned about the PK tail, but research is ongoing to clarify this as well. And lastly, what are the client level challenges and opportunities? So there needs to be a clear discussion with the client about their options, their PrEP options. What are the possible benefits and risks of each of them, and how to have the situation, the optimal situation that clients and providers can make this discussion and take and have the clients participating in the decision-making process. And finally, aside for the aspects related to the development and implementation of new PrEP agents, it's very important to keep in mind that individual level risks are necessary for the spread of HIV infection, while they are totally insufficient to explain population level epidemic dynamics. In fact, it's the interplay of several levels of risk that can explain the dynamics of the HIV epidemic among MSM and trans women. Overcoming this interplay is a major challenge that we face. To better understand the dynamic of the HIV epidemic, it's crucial that we acknowledge the higher order social and structural levels of risk that likely facilitate HIV transmission on a populational level. As we have seen, a greater scope of options for HIV prevention draws parallels from the contraceptive field, in which personal choice of contraceptive delivery type has increased acceptability, uptake, and real-life effectiveness. Regardless of effective care or prevention strategies, the response against HIV epidemic is not merely the pursuit of purely biomedical solution. We need a broader vision, one that encompasses the multiple and entangled aspects of HIV infection and people's vulnerabilities. Let's keep our hopes and thoughts towards that. I would like to acknowledge the several people who helped me with this presentation, and thank you again for the opportunity.